next I'm going to talk about is the golden rules. And I've called it the golden rules of cardiac imaging. In a sense, if I'd put up a talk, I'm going to talk about the Isuog guidelines, you probably would have gone out and grabbed a coffee. So I didn't want to do that. I said, okay, I am going to go through the guidelines, but I'm going to do it in a different way. So what I want to do is to start off and understand that, you know, of the 700 people we have altogether this meeting, there's quite a diverse level of expertise amongst those present. So some of what I'm going to say is absolutely goddamn basic. But I think I want to start with basic, and then we will sort of progress as we go through, and then hopefully I'll try and translate the golden rules into live scanning in a second. Just let me start my watch. So with regard to doing any scan, with regard to the golden rules, I'm going to start off those, which I've got 15 or 16 golden rules, and then I'm going to go to the Isuog guidelines, and rather than read out the Isuog guidelines, I'm actually going to go through the level of the stomach, the four-chamber, and the section analysis, and give you examples of what you're actually looking for in these sections without knowing all the specific sequences or findings you expect with the particular anomalies. So I want to start of all and say, okay, you take out Ravi's textbook of fetal cardiac diagnosis and you say, crikey, that's a big book with a lot of information. And it's the Bible in a sense, like Dario for fetal anomalies, Ravi's textbook. I'm not here as a publisher's advocate, folks. I'm just telling you what I see is the truth. These are standard textbooks for in the imaging of maternal fetal medicine. And you break it down, you say, okay, let me try and see exactly what it is. Well, there's the left heart anomalies, the right heart anomalies, and the override anomalies. Then there's the septal defects, the spatial arrangements, which is TGA, and then the venous anomalies, which are systemic and pulmonary. And then the rare, which you would, you know, rare. And then if you look at the heterotaxies, which are really a combination of these, and then forget about the soft markers and the borderline findings. I know I'm giving a talk on that. But essentially, if you boil down cardiac malformation, essentially you're dealing with a number of approximately 50 discrete sequences. So are you going to sit down and start learning about each of the 50 sequences? Well, probably if you're in the area of fetal cardiac diagnosis, yes. But many of you are maternal fetal medicine specialists practicing, you're going to say, a patient comes in to me, I want to know, is it abnormal? And in a sense, that's what I'm going to do is to go by step on the section analysis of what is abnormal on the abdomen. What do you expect to see? And the list is there of the anomalies that you're specifically looking for: the absent ductus venosus, the umbilical vein varix, the stomach on the right or left side, or swapping up the position of them. Instead of the IVC being anterior and to the right of the aorta, they may be side by side, or a hemiazygos may be left posterior. So they're the list of the things you expect to see on an assessment of the fetal stomach. That's what you would expect to see in examination of the four-chamber for all those 50 anomalies, and then the five-chamber and the three-vessel. The two biggest groups in all of these is the four-chamber and the three-vessel tracheal view. And if you look at simply those two sections of the four-chamber and the three-vessel tracheal view, you will pick up the vast majority of those 50 anomaly sequences. So that's what, in a sense, the handbook that I've created of those 18 pages is breaking them down by those 5 sections, and at the very end of the handbook is the images that match, in a sense, these 50 anomalies. So the golden rules, what are they? Well, I think if you're going to do any scan, you start off by looking at the descending aorta. So this is the descending aorta, and that defines the left atrium. So if you see a problem in this side, you can straight away, by looking at the descending aorta, say that's the right ventricular problem. Now that may say to you, well, that's very simple. That's fine with the apex of the heart pointing up. But when life gets difficult in large BMI patients in a transverse position, finding out where the descending aorta is and saying, that's the left atrium. You've anchored your point in the heart, and then from there, you can work out where to go to the next step in assessing whether there's an abnormality of a particular chamber. Golden rule number 2. When you're scanning, you always will have red up. When I say always, you aim to. Ideally, we always want to have the apex pointing upwards and the spine posteriorly. But for 90-95% of the scans we do, we push the baby, we get into position where it is with the apex up, or the apex at 11 o'clock, or 3 o'clock, or 9 o'clock. And if that's the case, inflow should always be red, and regurgitant jet will always be blue. If you look at the great vessels, flow through the great vessels will always be blue. It becomes like driving a car and changing from the first to the second gear. It becomes instinctual to you. If a baby has got tricuspid valve regurgitation, that you identify it straight away, because you examine every baby in the scenario where inflow is red and outflow is blue. And the advantage of that in the three-vessel tracheal view is you ever see red in this vessel here, you know that that's reversal of flow, because that's how you've done the last 10,000 scans or last 1,000 scans. So if I see the descending aorta is here, that tells me that's the left atrium, and therefore that's a right AV valve regurgitant jet, instinctual, and that's a mitral valve regurgitant jet. Golden rule number 3. When you're doing a scan, you look at the point of the trachea. In these machines, the trachea is readily available. In 99.9% of the scans that you do on a daily basis, the vessel that's closest to the trachea is the transverse aortic arch. That is such a helpful rule. And that doesn't matter what position the baby's in. If you identify the trachea, the next vessel that's closest to that will be the transverse aortic arch. And you say to me, Simon, sometimes I struggle seeing the trachea. I say, okay, then go for the SVC. I know some of you in the room are already thinking about exceptions to the rule, but the right aortic arch, the right arterial, the double aortic arch. But yeah, I know, but these are a tiny percentage. For the 99.9% of scans, that is a very, very helpful rule. Now, I've just given you 3 rules, and without even showing you the 4-chamber view of heart, if I show you this clip, straight away you tell me, well, the red and the blue is set correctly. You tell me that this is the trachea, and the vessel closest to the trachea, which is this vessel here in red, is the aorta. And that's telling me that you've got reversal of flow along the transverse aortic arch, without even looking at the 4-chamber view of heart. If you look at this case on the right-hand side, here's your trachea and your SVC. The vessel close to the trachea is the aorta, and therefore the reversal flows in the duct. So straight away I can tell you that this is a right heart obstruction or a right heart abnormality, and this one here is left. So it's a very simple rule applying those 3 golden rules in obstetric imaging. Because if you have a hypoplastic left heart, you know exactly where you need to look for the trachea, and you know exactly you need to look for jets of red to see where there's a reversal of flow in a hypoplastic left heart. Golden rule number 4. I think cine is underused in routine clinical practice in cardiac imaging. So if you look at this heart, you can see straight away that this is the descending aorta, therefore that's the left ventricle. And if you look at the left ventricle, see that the left ventricle is smaller when compared to the right. When you look at color flow across this, it's hard to work out with that degree of cine loop running what's going on with regard to the pulmonary veins coming into the left atrium. But if you take the same image and you slow it down, it's very clear. It's going from red to blue, from red to blue. There's bidirectional flow across the pulmonary veins. And this becomes very important in terms of counseling patients in the setting of a hypoplastic left heart, whatever the cause of the hypoplastic left heart is. Similarly, another hypoplastic left heart, you know, because here's the aorta, it's the left ventricle. And as you look at this left ventricle, you see it's also undersized in the first trimester scan, but there's also a common venous channel. This baby has got total anomalous pulmonary venous return. But not only has it got total anomalous pulmonary venous return, you're seeing bidirectional flow with cine loop set at low, and therefore you know you have obstruction in the venous system with total anomalous pulmonary venous return. This was a supracardiac type. So the power of cine in slowing things down. Golden rule number 5. In terms of imaging, in cardiac imaging, it's a very useful thing to split your screen and to show 2D on one side and to show color on the other. And the advantage of that is, number 1, I do that routinely because I want to know are my color Doppler settings correct? Do I have overfill of a vessel? If I'm going to call coarctation, I see far too much or not enough color on it. But if I've got 2D beside me, I know exactly what the fill of that vessel should be. For the experienced operator, you can have a single screen with color, and you know how to manipulate your color to get the precise fill of that vessel. But when you're learning, if you match 2D with it, you will get to realize it's a very powerful tool in cardiac imaging. In this baby, when you look at it, you can see on color that there's a regurgitant jet, but there's so much color going on there, it's hard to actually work out exactly where that jet is originating from. But if you look here in the 2D image, you can actually see the point of the vena contracta. you can see the exact point of where that regurgitant jet is arising from. This becomes important in terms of distinguishing, say, tricuspid valve dysplasia with Epstein's anomaly. So in terms of 2D splitting is a very powerful tool in routine screening. Golden rule number 6. If you look at the handbook, I've made a comment, I think almost given a page to the right ventricular outflow tract, because I think half of the time when we look at it, we don't look at it properly. And I ask you a question, and I should, before I even said that, I should have asked you the question first. Is that a normal 3-vessel view? And I think for most people in same term, I say, yeah, that looks like a normal 3-vessel view. Why? Because the pulmonary artery is larger than the aorta, is larger than the SVC, the normal order of sizes according to the Isuog guideline. But for me, that is not a 3-vessel view. It's part of a 3-vessel view because I can't see the pulmonary valve. And to be honest with you, you know why I think we miss pulmonary stenosis in the 3rd trimester? We're lousy at picking it up. It's because we end up producing 3-vessel views like this, or we produce a 3-vessel tracheal view. We don't visualize the pulmonary valve. If you're serious about visualizing the pulmonary valve, you have to have the right ventricle in view at the same time. So in fact, when you're looking at the right ventricular outflow tract, you see the origin of the main pulmonary artery coming out of the right ventricle. You see that it's got convexity to the left, so the curvature is in the correct direction. Then you look at the pulmonary valvular anatomy, you see that the valve disappears during ventricular systole. And then you look at the 3 components as per I've outlined in the handbook. So when you're looking, and when we do it in the live scan, it's a dynamic assessment as you sweep from a 4-chamber to a right ventricular outflow tract, and you try and keep the right ventricular wall in view, because if you do, you will then bring in the pulmonary valve into view. And I think that will improve, in a sense, your detection rate of pulmonary valve stenosis in the 3rd trimester. You also know the way the vessel comes out of the right ventricle is the convexity of the vessel to the left. And that becomes important from the point of view of picking up transposition of the great arteries. So here we have a right ventricular outflow tract in my golden rule number 6, and I have the right ventricular wall in view. With the right ventricular wall in view, I now have the pulmonary valve in view. I'm happy with that image. And I also have the branching into the right pulmonary artery and the aorta. And when I look at the curvature of that vessel coming out of the RV, it's curving to the left. But if I do it and it's curving to the right, the odds are that I'm looking at transposed great vessels. Most commonly, transposition of the great arteries. So if you, every single day you go to work, you split the screen. You show on the left-hand side the 4-chamber view of heart with the right ventricle in the view. You then update and you have showing the right ventricular outflow tract and you've got the curvature and you compare it to the 4-chamber. It becomes instinctual to you if it's coming out in a reversed direction. And your detection rate, not just for 2nd trimester, but for 1st trimester of transposition of the great arteries, which still remains a very challenging diagnosis, will improve. Damn it, I forgot to start the watch. Golden rule number 7 is the rule of 100. And it's a very simple rule, is that pulse Doppler velocities of any vessel, any chamber, atria, ventricles, aorta, pulmonary artery, the duct which has got the highest velocity of flow in the fetus, is never more than 100 in the mid-trimester. So if you ever think, because Doppler can produce such crazy images for you, you think there's an abnormality, there's aliasing, you've probably got your Doppler settings wrong. But if you're not trained in the maximizing the machine to how it should be in the correct settings, in terms of getting a pulse Doppler gate, if you put a pulse Doppler gate over any vessel that you're concerned about, and you get a reading that's more than 100, the odds are you're probably looking at something that's abnormal. And if you want to be specific about it, these are the Rizzo charts when we looked at it. If you look at what the 50th centile is around that stage, it's around about 50 centimeters a second. And then if you look at your standard deviation, it goes up to around about 74, which makes a very relevant point that if the mean is around about 55 centimeters a second in the mid-trimester, that's what you should set your PRF at. So in doing a 1st trimester scan, it's about 25 to 35 centimeters, 2nd trimester scan, 55 to 65, because the mean velocity is around that time, and that's when you want to get the vessels filled. If you suspect that you're seeing turbulence, then you increase your PRF. And if you're increasing your PRF to the point where it's 100, you know that 100 is way beyond 2 standard deviations from the mean. You're looking at a valvular lesion. whether it be tricuspid valve regurgitation, whether it be pulmonary stenosis, aortic stenosis, whatever it is. But now, of course, we have more updated charts since Rizzo's chart. And if you look at the upper limit of normal, it's actually 120 centimeters. But who does scans at 38, 39, 40 weeks? None of us do that. We do our screening examination when we're around 20 weeks of gestation. And if we look at the more recent data, you're still around about 80 centimeters. So the rule of 100 is a very useful rule. Next rule, rule number 8. If you are ever faced with a situation when you think there's a valvular abnormality, a pulmonary valve or aortic valve abnormality, one way of getting out of trouble is saying, I wonder whether it's my Doppler setting that's giving me this abnormal reading, is simply move the pulse Doppler gate across to the other great artery. So in a situation where I'm faced with this, I'm looking at the left ventricular outflow tract, I place my pulse Doppler gate distal to the aortic valve, and I get a velocity that is over 120 centimeters a second. I wonder, are my settings correct? If I simply update by clicking the right button and move to the pulmonary artery, I then look and get the pulmonary artery and getting velocities around 48 centimeters a second. I know it's real. So in a sense, if you're ever faced with that scenario, compare one vessel to the other. Rule number 9. I work in a fetal medicine unit at the Mercy. You know what the probe is that breaks most often? The C1 to 6 probe. Because that's the probe that every maternal fetal medicine person picks up. You know why? Because a high proportion of their patients are large BMI. And you want to muck around starting off with a linear 9, change over 3 probes, a couple of minutes have gone by. It's the probe that breaks most often because it's the most used probe. And what's the probe that never breaks? The linear 9. Because nobody ever picks up the linear 9. The point I'm making is to be honest with you, in screening a cardiac assessment, I think you have to do more than one probe because you don't know if you're working on an optimal frequency until you try another probe lower or higher, depending what the clinical setting is. So I think you have to go through that learning process. I know it takes a little bit of extra time, but it is worthwhile. Because if you swap from looking at what you can see with the starting off with a C1 to 6 in this baby with a bilateral superior vena cava, vessel close to the trachea, the transverse aortic arch, laminar flow across the great vessels, but instead of having 3, we have 4 vessels. You then sweep across to coming down to moving to the linear 9, and I'll just speed it up, moving down to the linear up to 15 megahertz. Not only can you see there's a bilateral SVC, but you can see streaming of the persistent left SVC draining into the coronary sinus. That's the power of frequency. Rule number 10. This is a medical legal point. Is in terms of missing situs inversus, or in terms of missing the heterotaxis, it becomes a medical legal issue. They go back and they pull out your films and they say, oh, did you look at situs? Well, it's very hard to ask an examiner if you looked at situs if you look at all the images, because it's very dynamic. But if you specifically have taken a picture showing a split image of the stomach on one side and the heart on the same side of the stomach, you draw a line through the spine, 2/3 of the heart is in the left hemithorax, you've shown that you've documented that the situs is correct in this baby and you've recorded to your hard drive. That is part of the very initial assessment of doing an Isuog guideline. Rule number 11. In terms of ventricular septal defects, and Rabi will cover this, but this is a diagram I love because it shows the individual portions of the septum, and it shows not only individual portions of the septum, but it shows in all the different sections in which you will see septal defects. I won't go any further because Rabi will be covering this, but reason why it's a rule number 11 is this is an image you need to be familiar with how to get. Because we're all fine with the inlets and the musculars and the perimembranous, but we all struggle with the outflow tract VSDs. So how do you get an outflow tract VSD? You start off with a 4-chamber view of heart. You sweep up to the right ventricular outflow tract. And once you've got the right ventricular outflow tract with the 3 vessels, you simply rotate the transducer. And when you rotate the transducer, you bring the RPA into view, and you trace a little bit further. You now have the tricuspid valve, you have the pulmonary valve, and the aortic valve. In a sense, it should be called the 3-valvular view, because it's at this point that you are going to see your outlet septum defect, exactly what's listed in green, tricuspid valve, pulmonary valve, and in the center, the Mercedes-Benz sign. So this is a patient from a few weeks ago. When you look at the tricuspid valve here, the pulmonary valve is just below the level of the pulmonary valve. On a split image, you can see this is your defect. And you can measure your defect. And here you can see the wash of color coming across from your aorta. So that part of the outlet septum between the great arteries. Rule number 12, very simple rule. Should never see mitral valve regurgitation. Tricuspid valve regurgitation is a common benign finding which we all see, but if you ever see mitral valve regurgitation, whether it be tiny or very significant, descending aorta, left atrium, there, this is your mitral valve. Mitral valve, take seriously. Rule number 13, looking at ARSAs, ideally you want to have it in a position where you're either scanning towards the right or left shoulder. I'll spend very quickly on this because many of us are not imaging it anymore in routine screening because of the arrival of cell-free DNA, but we continue to look at it. Why? Because I believe it's a marker for congenital heart defect. And when you look at this in the same baby, you can see it also has a muscular ventricular septal defect. Rule number 13 is actually part of the same rule. I struggled, for quite a while with this baby because I could see on 2D that there was an aberrant subclavian. But despite every single setting that I went down to 11 centimeters, I could not get fill of the aberrant subclavian. I hit one button, slow flow. And in a single button press of slow flow, the aberrant subclavian comes up. It's beautiful technology. I generally use it most in the first trimester of pregnancy and second, and less so in the third trimester. Rule number 14. In this situation, when you suspect that there's an AV canal defect, you're looking at this image with the apex of the heart up around 12 o'clock. Now you want to try and assess, okay, am I looking at a complete or a partial AV canal defect? You say, well, how am I going to get to that point where I get a axial section of the heart? You will never get an axial section through the heart with the apex pointing up at 12 o'clock. Never. You can try all day long. You have to switch it such that your apex is at 3 o'clock or at 9 o'clock. And once you do that, you flip your transducer 90 degrees, and then you will get to the point here with the apex at 3 o'clock. I then flip the transducer 90 degrees, and here I have my mitral valve, the intraatrial septum, and here's my tricuspid valve. In the same fetus here on the right-hand side, using a linear 9 probe, flip the transducer 90 degrees using slow motion, slow-mo. You see we have a complete AV canal defect with no bridging tissue. So the rule of thumb is in that one is get the apex at 3 o'clock to 9 o'clock before you even attempt. Okay, so in terms of going through the Isuog guidelines, I then go to the next step where these are the section analysis, and you can read the Isuog guidelines, but I'm going to take you through in terms of the sections of what you would expect to see in examining the stomach, and this is going to be quick because this is pattern recognition that I'm sharing with you, not technique on how to do a scan. But for every pregnancy that you do, you look at the stomach, the intrahepatic vein should sweep away, and the gallbladder should be on the far side. The aorta to the left of the spine, and IVC anterior to the right. Probably the most straightforward and easiest section of them all. In this case, when you look here, you've got the stomach, which is on the right-hand side, and the heart, which is on the left. Completely structurally normal heart. But again, it's examining that first level, the stomach, that you pick this up. Rabbi will be talking about the heterotaxis, but you should never see two great arteries side by side at the level of the stomach. The IVC should always be anterior and to the right. When you look at the stomach in this position, the gallbladder should never be sandwiched between the stomach and the intrahepatic vein. It should be on the opposite side, persistent right umbilical vein. When you look at the intrahepatic vein, it should curve away from the stomach, but this one continues all the way to the IVC. Absent ductus venosus. When you look at this case in the stomach, you see the varix, that very bulbous appearance of the intrahepatic vein, which is extrahepatic for most, or you may have the intrahepatic umbilical vein varix. When you look at this case, it doesn't need any measurement. You can see that that's very grossly dilated. Section number 2. When looking at the heart and a four-chamber view of heart, one of the most common you will see of the major abnormalities is hypoplastic left or right. How do I know it's right? Because that's the descending aorta, that's the left atrium, that's the left ventricle, and therefore at a glance, I can see that that is a hypoplastic right heart within an instant. When I look at this image here, both of these first trimester diagnoses with the descending aorta here, that's the left atrium, that's the left ventricle. It's a hypoplastic left heart. And again, a diagnosis that we make in the first trimester of pregnancy. When you look at this heart and you draw a line to the chest, you see, in fact, the heart is situated centrally within the chest, mesocardia. 2/3 of the heart should be in the left hemithorax, and 1/3 should be in the right. And not only has it got mesocardia, if that's the descending aorta, well, then that's a hypoplastic right heart. When you look at this case, is the apex of the heart is rotated to the left. How do I know? Because that's the descending aorta. So this is a hypoplastic left heart with left axis deviation. So looking for mesocardia, axis deviation are very powerful markers of cardiac abnormalities. More importantly, axis deviation. So that's small left ventricles that I've just described, as demonstrated in this case on the left-hand side. You may also have enlarged left ventricle, a rarer finding and mostly typical of critical aortic stenosis. In this case, you may have a small left ventricle in this case, in a baby pulmonary atresia with intraventricular septum, but these are the anomalies that you'll expect to look for with a small right ventricle. Again, section by section, these are listed in the handbook. In this case, you know that this is the descending aorta, left atrium, and this is a dilated right ventricle. And this is your differential diagnosis that you'll expect to see of all the causes of an enlarged right ventricle. In terms of tumor, very straightforward diagnosis. I'll skip it because you all spot that at a glance in terms of rhabdomyomas. And in this case here, ventricular septal defects. Ideally with these, I know cardiologists like to examine them with the apex at 3 o'clock or 9 o'clock. From our point of view, we prefer the apex more at around 2 o'clock or 10 to 11 o'clock in identifying ventricular septal defects. In terms of atrial septal defects, far more challenging because you're looking out at the dropout in the region of the atrium septum. And Rabbi will talk about the importance of flow direction in distinguishing coronary sinus dilatation versus ASDs, prime ASDs, difficult diagnosis. In terms of the size of the heart, and if you look at the Isuog guidelines, anything when you get a cardiothoracic ratio more than 60%, you start needing to get suspicious of all the differential diagnoses which I've listed in the handbook. Tricuspid valve regurgitation, I'll be talking separately about that, but 5% of all pregnancies you will see that. So important to get your settings right. But for most of these, there are a benign finding. In this case, moving to the atria, enlargement of the atria in a first trimester scan in a baby with atrial aneurysm, and in this baby with Epstein's anomaly. So again, looking at the symmetry of the atria is an important part of the four-chamber view assessment. And don't forget the area behind the heart. I've already mentioned about the total anomalous pulmonary venous return, but there should only be a single vessel sitting behind the heart, which is the descending aorta. So if you see a second vessel, you need to consider interrupted IVC with azygous continuation. And if you ever see a third vessel, it will almost certainly be transient. It's just the esophagus. But this is a very powerful view for looking at multiple arterial pulmonary collaterals, sometimes more helpful in a four-chamber view than looking at sagittal imaging of the arches, looking for collaterals in the setting of tetralogy fallow or pulmonary atresia. So moving up onto the five-chamber view of heart is the abnormality. You see the numbers you will see on my section as are much smaller. And there are 5 things you need to look at in the left ventricular outflow tract. Number 1, the continuity of the interventricular septum with the anterior wall of the aorta. Number 2, the aortic valve. Number 3, the caliber of the ascending aorta. Number 4, the curvature, so it doesn't have a straight curvature of tetralogy of fallow or trunks. And then you need to see on color Doppler laminar flow. These are the 5 key practical things you need to look for in assessment of a 5-chamber view of heart. What may you see in this is then looking at a 5-chamber that you may see that there are signs of a perimembranous ventricular septal defect. I know what you're thinking. You're thinking, I think this is a Fallow's, or you're thinking maybe it's just a malaligned VSD. Or is it in fact artifactual? Or are you looking at an oblique section through the heart? And I'll come back to that. In this case, tetralogy of fallow, if you look at the 5-chamber, this is the section we pick up: tetralogy of fallow, double outblind ventricle, and common arterial trunk. And we will go through this later on this morning. In this case, when the aorta is more than 50% stride, now moving from a fallows to a double outlet right, and in the setting of a common arterial trunk, you can see the type 1 with the branching of the pulmonary artery. But it's the 5-chamber view that brings you to these diagnoses. Apart from the co-truncal abnormalities, this is more commonly seen in the third trimester, where the valve does not disappear during ventricular systole. And when it doesn't disappear during ventricular systole, you also see that the aorta is dilated. If you didn't appreciate that, you will appreciate that you will have turbulent flow. And in fact, for many of those with aortic stenosis, the diagnosis is made on color rather than this nice case, which I show you, which shows dilatation of the aorta. For many of them, you will not get that dilatation. With regard to looking at the 5-chamber view, if you see the vessel coming out of the left ventricle bifurcates, well, that's very abnormal because it's the aorta should be coming out, not the pulmonary artery. This, however, in terms of making a diagnosis of transposition of the great arteries, there are easier ways than demonstrating that bifurcation. It took me a while to produce that video clip showing that bifurcation. It's not one of those things that strikes you straight away with the TGA. And in this case here, we have a posterior malaligned VSD. And anytime you see a posterior malaligned VSD, you need to think of aortic interruption. And finally, on that slightly rotated, the both vessels coming out in parallel, and then looking at a 5-chamber in the pulmonary atresia, with intact ventricular septum, coming off the dilated aorta, you can see the coronary artery collaterals. So these are all the things that you can see in a 5-chamber assessment. From a right ventricular outflow tract point of view, again, you need to understand there are 3 components to it. So if you sweep from the right ventricle here, continue all the way up, this is the arterial duct, the aorta, the SVC. In this case here, which is a more common way you'll see it, which is the aorta, SVC, the right ventricular wall, pulmonary valve, and this is the RPA. Remember, the RPA should always be smaller than the aorta. If you find that the aorta is looking around the same size or smaller, you need to think of coarc. And then the reverse side of that equation, if the RPA is dilated, you need to think of absent pulmonary valve syndrome, but that's rare. And then the third way in which you may see the right ventricular outflow tract is you sweep up, you see that bifurcation into the left pulmonary artery and the right. The right is always far more difficult to see when compared, the left is far more difficult to see when compared to the right. So in this case, you just sweep here on color Doppler examination, you see the pulmonary artery is smaller when compared to the aorta. You can see in this case, not only is the pulmonary artery smaller when compared to the aorta, but it is a proximal insertion. So you have the very abnormal 3-vessel view. But remember, in the 3-vessel view, the pulmonary artery should be larger than the aorta, which should be larger than the SVC. You know, when you do a scan on Monday morning, let me ask you a question. You sweep from the 4-chamber view up to the neck. What's the first vessel that you see? The first vessel that you see when you sweep from a 4-chamber should always be the aorta, the first vessel. So if you're sweeping up from the aorta, the next thing at right angles to that is then the pulmonary artery. The aorta disappears. If you were ever sweeping from a 4-chamber view and you see both vessels coming out side by side, you're not seeing the aorta first and then the pulmonary artery. You're actually seeing them coming out side by side. You're almost certainly going to be looking at a double outlet right ventricle. And we'll be talking about that later in the morning. But the point I'm making is, from a screening context, remember, the first vessel you see from a 4-chamber heart is looking at the aorta coming out. And again, you will see this in the first trimester scan. You sweep from a 4-chamber. You do not see coming out the aorta first. You see both vessels coming out parallel in a patient at 13 weeks of gestation. And another case here showing with color Doppler, both vessels coming out in parallel. Lastly, with regard to the right ventricular outflow tract, if you split the image showing that this is inflow into the ventricles, and then you sweep, you know the pulmonary artery should be coming out in this direction, but it's coming out in a reverse direction. And probably the more powerful thing, which I should say with regard to TGA when you see this, is there's only 2 vessels on the 3-vessel tracheal view. But then when you only see 2 vessels, and you ask yourself, that's a big differential diagnosis. The next thing you say to it is, what is the curvature of the great artery? Because if it's convex to the right, it's almost certainly going to be TGA. If we move up to the 3-vessel tracheal view, this is a triumphant view. It was a triumphant view because it was the point in time where we realized, when you look at the trachea, this is the transverse aortic arch. And when you look at the transverse aortic arch, it was this view that we learned that we'd be able to pick up coarctation of the aorta. An extremely challenging diagnosis with lots. We'll address the issue of false negatives and false positives. But we were able to identify the isthmus after the left subclavian artery was given off and before the duct joined. That segment could be appreciated on a 3-vessel tracheal view. So when we were faced with the scenario where there was discordance at the level of the isthmus,
That's when we started to realize we could appreciate coarctation of the aorta. It was a game changer. But at the same time, it's a point where I've already commented on in terms of reversal. These are different cases. If that's the trachea, that's showing reversal of flow. That's a right heart lesion straight away, because you see there's forward flow in the aorta. And if we look at this case here, we can see there's the trachea, and this is a reversal of flow along the aorta. That's a left heart obstruction. It was also the view in which we could see right aortic arches. In this case, the trachea is right in the middle with the U-shaped configuration, or we could see that the aorta is splitting in two with the double aortic arches, which for both of these we can pick up in first and second trimester. And then the more subtle variations on it, where you get atretic branches, where you get a dominant right branch and an atretic left branch. Again, you can pick this up on the three-vessel tracheal view. It's also in this view we see the aberrant subclavian artery. When you look at the chest and the spine, the subclavian should come off about halfway. But if it tracks behind the trachea, which is your reference point, there's your aorta, we're looking at an aberrant subclavian. Again, we can see these in the first trimester of pregnancy, but their significance is diminished in the world of cell-free DNA. We all know that you should only see three vessels in three-vessel tracheal view. There's 1, 2, 3, and there's a fourth vessel. And when you look at that fourth vessel, it's going in a different direction of flow to the other. And that's an ascending vessel of total anomalous supracardiac pulmonary venous return. In this case here, which is a far more common scenario, is you have 1, 2, 3, 4 vessels. You know that's the trachea, that's the aorta, that's the pulmonary artery, and that's the persistent left FVC, applying all your golden rules. You should never have a vessel sitting beside the pulmonary artery, if I can throw in golden rule number 16. There should never be a vessel beside the PA. In this, when you sweep from a three-vessel to a three-vessel tracheal view, in this case, when you look at this on the left, this screen on the left-hand side, there's no flow into the right side because this is your descending aorta. So there's no inflow into the right ventricle. And when you sweep up to the three-vessel tracheal view on a split image with color Doppler, you appreciate there's reverse convexity. So you know this is quite a complex cardiac abnormality, but it's a hypoplastic right heart with tricuspid atresia with transposed great arteries. But again, by adopting all those simple principles that you come to that diagnosis fairly quickly. Now I ask you a question. Is this heart normal? You're sweeping up here, starting off, your basic principles. The stomach is on the left-hand side, the heart is in the left side of the chest, and you sweep up to the three-vessel tracheal view, and you look at the three vessels, and they look to be of similar sizes. The aorta is larger than the pulmonary artery is larger than the aorta, then larger than the SVC. But if you go to your point of where your trachea is they're actually sweeping to the right side of the trachea. So this is a right aortic arch with a right arterial duct, and it's an exception to the rule, because the vessel closest to the trachea is in fact not the aorta, is in fact the arterial duct. And when you look at this particular case, the pulmonary artery is dilated. You place your pulse Doppler gate distal to the valve. Why? Because you brought the right ventricle into view, and you can see the valve is thickened. So it's a right aortic arch, right arterial duct with pulmonary valve stenosis. And lastly, looking at the left brachiocephalic vein, when you come up in this fetus, you should never see a vein of that size. You should be familiar, in a sense, of what the size is of the brachiocephalic vein. For many of these, when we see these dilated brachiocephalic veins in the setting of severely growth-restricted babies, maybe in the setting of vein of Galen aneurysm, but I've already told you there shouldn't be an extra vessel beside the pulmonary artery. And you already know that that's the trachea, and therefore you know that that's the aorta, and you know that that's the pulmonary artery, without even looking at the fourth chamber. And as you do so, you see there's an extra vessel sitting beside the pulmonary artery and draining into the brachiocephalic vein. So before you even look at the fourth chamber view of a heart on this baby, you can say it's got likely to have anomalous pulmonary venous return. Your differential, that would be your bilateral SVC. In summary, in terms of a practical approach to looking at a cardiac imaging, yes, you can take out the Isuog guidelines, and I do encourage you to do it. But for each of the sections of those, ask yourself what is it that I expect to see in the 50 anomaly sequences that are laid out in any prenatal screening context? And when you know what to expect to see in those 5 sections, it might make life a lot easier, just from a screening context, to pick up that something is not right. Because the expectation is not for all the 700 people at this meeting to know what are the sonographic appearances of all of these 50 anomaly sequences. That takes so many years of training to get to the point where you have an instinctual response saying, yeah, it's number 7047, that's a classic whatever. So I'm hoping those golden rules and a quick guideline through Isuog assessment in the mid-trimester is helpful. Thanks very much for your attention.